seminar on osteogenic lesions of clinical pathology. All right, so welcome you all. So these are some of the reminders, a few disclaimers. So a slide on upcoming talks. The next slide seminar will be by Dr. Rajiv Joshi on skin biopsy interpretation on 3rd April. And then on 4th April, we have a talk on approach to soft tissue tumors by Dr. Praveen Mahajan. So let's start with our slide seminar now.
Are you going to start or should I start? I forget.
Sir, whichever way, like you say.
You want to just do the radiology to start off with? If you have a sort of a basic interpretation of radiology, then that might be a good way to start.
So that's fine, sir. I have 7 slides for radiology. I'll start with that.
Okay, let's do that, and then I'll get into the cases.
Sure, sir.
Okay.
So are my slides visible, sir?
Yes, they are.
Yes, okay. So this is a basic bone tumor radiology for the pathologist. So, and it's a very simplified version how to read radiographs for to understanding what kind of tumor that we are dealing with. So basically what we see in a radiograph is a 4 very relevant points. First is where is the lesion? Second is what is the lesion doing to the bone? Third is what is the bone response? And fourth is anything suggestive of histology, which is very relevant for the pathology, which is the matrix of the lesion. So if we are able to answer these questions, then more or less we'll be able to reach a differential, whether we are dealing with a benign tumor or a malignant tumor, and what are the possible differentials. So I'll go these points one by one. The most important point, the first point is where is the lesion, for which what we are concerned is not the upper end or the lower end of a bone. It is basically the type of bone, whether it's a flat bone or a long bone. And if it is a long bone, whether the lesion is on the cortex or on the surface or medullary. And whether the lesion, if it is medullary, it's diaphyseal, metaphyseal, or epiphyseal. So we are not concerned whether it is upper end or lower end, but what we are concerned is whether it is metaphyseal, epiphyseal, or diaphyseal because of our differential stages. So these are some examples. So if you ask me where is the lesion in this case, this is in the metaphyseal, going up to the epiphyseal area, right up to the subchondral area. Another lesion now looks more aggressive. I'll be discussing why it looks more aggressive, but yes, the location is same, metaphyseal going into the epiphyseal area. Another lesion which is now metaphyseal, but now going to diaphyseal, expansile, and appears benign. We'll be discussing why it appears benign, but yes, it is sparing the epiphysis of the lower end of ulna. Another lesion, there are certain lesions which are common in the certain part of skeleton, like now this is a lesion in the sacrum, where the differentials are mainly the giant cell tumor, chordoma, or a metastasis according to the age. But yes, there are certain lesions which are common in flat bones as compared to the long bones. Second, and the very important question is the pattern of destruction. I think we should understand what is the pattern of destruction. We call these the 3 patterns. One is geographical, moth-eaten, and permeative. By geographical, what I mean is you should be able to draw a line between the tumor bone and the normal bone. If you are able to do that, as I can mark here, we can easily draw a line with a pencil. So that means it is a slow growing lesion. The tumor is causing a bone destruction without invading more of the bone. So this mainly suggests a benign kind of a tumor. The other 2 patterns are aggressive patterns, which is moth-eaten, where there is a single big lesions and small radiolucency around it, or there is a permeation of bone. So both moth-eaten or permeation is suggestive of a aggressive or a malignant bone pathology. And what we also should note is any pathological fracture, because if there's a pathological fracture, as Dr. Deshpande has mentioned in his previous presentation, it can cause a new bone formation, which will be very confusing for a pathologist, because you will see a chondroid, you will see a proliferative osteoid, so that becomes confusing. So we should always see what all is the lesion doing to the bone. The third question is what is the bone response? Here we see 2 important things. First is a marginal sclerosis, and second is periosteal reaction. By marginal sclerosis, what I mean is the endosteal border shows a sclerotic rim, So this is classical for benign lesions. And if you find this sclerotic limb, that means bone is getting lot of time to wall off the lesion. And this usually suggests a latent tumor like a non-ossifying fibroma or a fibrous cortical defect. So a marginal sclerosis is very important because first thing it suggests benign. Second thing, it usually suggests an incidental finding or a latent lesion. The other kind of a bone reaction is a periosteal reactions, which could be aggressive like a sunburst appearance, which we see in osteosarcoma, or a layered periosteal reaction, as you can see here, which is we call as an onion peel periosteal reaction, which is classical for EVs. The last important point in reading a bone tumor radiograph is a matrix. We have four different kind of matrix: a bony matrix, a cartilaginous matrix, a ground glass matrix, or no matrix. So this is a classical bone matrix where you will see a dense bone next to a normal bone. So the tumor is actually forming a dense kind of a bone which appears almost similar to the normal bone. So this is classical for a bone forming tumors like an osteosarcoma, parosteal osteosarcoma, periosteal osteosarcoma. This is classical chondroid matrix where you will see a specks of calcification in the lesion. So this is classical for chondrosarcomas. This is a ground glass matrix where you can see that the bone is in having certain lesions which looks little translucent as compared to the rest of the bone. So this is classical for the fibrous lesions like a fibrous dysplasia. And this is classical for a no matrix lesion, as you can see in the lower corner. You can see actually through the bone, you can see actually the soft tissue shadow, which is similar to a soft tissue shadow outside. And the classical no matrix lesions are either Ewing sarcoma, or if it is benign, it is a giant cell tumor like in this case. So basically, for pathologists, this is what we call as a discriminator. I call it as a 2x2 design. If you see a narrow zone of transition, no periosteal reaction, more or less you are dealing with a benign tumor. If you see a wide zone of transition like a moth-eaten or a permeative destruction, aggressive periosteal reaction, you are dealing with malignant lesion. And you have differentials according to age. If it is a benign lesion in a mature skeleton, metaphyseal, going to subchondral, you know it is giant cell tumor. But yes, epiphyseal benign lesion, you know it's a chondroblastoma in a young age. Similarly, a bone-forming lesion with a wide zone of transition and aggressive periosteal reaction is an osteosarcoma. A non-bone forming with wide zone with aggressive periosteal reaction, you know it is ET. So this is a very like a very basic to understand radiology, but you should remember these discriminators, and I think this will help you a lot in understanding what you are going to see on the slides. So with this, I think I'll stop, and if there's any question, I'll take, and otherwise we'll do a quiz later.
That's terrific, Manish. I mean, I haven't seen it put so beautifully before. You know, in the space of 10 minutes, Manish has essentially given you all that is there is to know. Uh, I'll just make two additional comments. One is I think it's important to know some basics of radiology simply because you need to speak the same language as the radiologist, right? We all need to learn to speak, all of us speak different languages. Um, so you know we need to learn to speak each other's language, then therefore communicate better. And the other thing is, you know, my approach generally is I always start by looking at the slides under the microscope and then walk across to the radiologist. You know, for example, we had our tumor board this morning, and you know, I'll stop the radiologists and ask them as they show slides. So we have quite a conversation. Occasionally, you know, if it's a longer conversation, I'll actually go down to their office, or we do it on Zoom, of course, these days. Sometimes they'll be able to tell you what it is, you know, like fibrous dysplasia, this is ground glass, this is fibrous dysplasia. And I'll tell them, look, I don't have it under the biopsy, but it's probably fibrous dysplasia, or perhaps there's a little bit of tissue. Perhaps it's compatible with fibrous dysplasia, but there I'm relying more on the radiology than on the pathology. And occasionally they can't really make a definitive diagnosis, but you know, my question to them always is this benign or is this malignant? And very frequently they'll tell you, you know, I think this is malignant, or I think that this is benign. And that to me is very, very helpful. You know, I sleep so much better at night. If I call something benign and the radiologist tells me it's probably benign, I tend to sleep a lot better. So anyway, with that introduction, let's get going. I'm going to share my audio, share my PowerPoint, and Let's see. What screen are you guys seeing?
Yes,
It's
sir.
got the YouTube.
The Twitter and the YouTube.
Okay, yeah. So
And
you're seeing full screen, right? Full screen mode.
Yes, sir. Full
Okay,
screen.
good, great, great. Yes. So a little plug for my Twitter page. So if you aren't on Twitter, go join Twitter. I think Pat Twitter is a great place to be. I do have a number of videos on my YouTube channel, a number of bone videos. I might play one or two today if we have time. But if you're interested to go, it's a fairly successful YouTube channel, and I've just enjoy doing this. To be able to teach across the entire world is truly a joy, and the feedback I've gotten has been awesome as well. So if you're interested, to go there. All right. So case number one. Is there someone who's going to be describing this?
Yes, sir.
Sharmila?
So, uh, 34-year-old
Sharmila, right?
gender. Yes, sir. Sharmila. Am I
Yes. Go
audible?
ahead.
Yes.
Yes, very much so.
We were given a history of 34-year-old, male or female was not specified, female lesion. So,
Okay. So
radiology.
let me stop there, and I'm going to ask Manish to interpret the radiology. I'm also going to ask him to tell you why that history is wrong.
Okay.
Hmm. So, sir, this is an X-ray of an immature skeleton. The
Right.
first thing
Right.
that you
So,
have to comment in the X-ray is a skeleton. So you can see the physes are open.
No fusion.
Yeah. Yeah.
the physes are open. So this is a kid. So the history I gave you is wrong. I confess, I make up these histories often, sometimes just to hide the patient's information. But in this case, I was so way off track. Manish, you wanna help Sharmila with this?
I think let Sharmila start, sir. I've just taught her.
Okay. So now you've had
Let
a
her
little bit of
start. Yeah,
primer.
and
Why
I
don't you
want.
start and try and interpret this? I know you haven't seen this before, but
Yes,
give it
sir.
your best shot.
It looks like there's a lesion in the epiphyseal-metaphyseal region.
Very good.
Metaphyseal, diaphyseal.
Met-
Epiphysis is free. Epiphysis is above the physeal cartilage. Yeah, above the physeal scar. It's a
It's
metaphyseal
the
diaphyseal.
epiphysis.
Yeah,
okay, so metaphyseal-diaphyseal lesion.
yeah.
A little
So
bit of
Sharmila,
rimming is there, sir. I can.
Sharmila, there are two discriminators. One is zone of transition, and second is periosteal reaction. So what do you feel is the zone of? Can you mark the lesion with the between the normal bone and the tumor?
Yes.
You should be able to
This,
mark this lesion. Yeah,
this I am
yeah,
able to mark, sir. There is
yeah.
a clear delineation between the lesion and the adjacent normal bone.
Especially the upper part. You can clearly demarcate at least the upper half of the lesion.
Hmm. Yes, sir.
Yeah, and can you see any periosteal reaction?
No, sir. No, it looks like a geographic lesion, but there's no
Perfect,
permeation or moth-eaten appearance seen.
perfect, good answer. And no periosteal reaction.
Hmm.
And what do you feel the matrix of the lesion is?
I am not certain about that, sir.
Yeah, so I think in one view, sometimes it becomes difficult if there is some overlap of the soft tissue shadows. But yes, to me, it looks like there is some osteoid in the matrix.
Yeah.
Yeah, to me, it looked like, although upper part looks no matrix, but yes, it looks like there is some matrix here.
Maybe cysts. So there may be some cystic change.
Yeah. So there
That
may
does look a
there may
little
be
ground glass, perhaps.
yes, yeah,
Sort of this sort of haziness, sort of diffuse
yeah.
haziness. So are
So
we,
Sharma,
Sharmila, are we thinking benign or malignant?
I'm thinking it's benign, sir.
Okay, so good. So now you have your histology. So let me just flip through the images really quickly. Right, so those are our images we have. Do you want to start describing it?
Yes, sir. So basically, in the low part, there are multiple cores, and it's
Yeah.
composed of a highly cellular tumor with spindle to elongated morphology, but predominantly bland looking. Hyperchromatic nuclei, inconspicuous nucleoli, and there appears to be like a vague storiform pattern of arrangement, sir.
Yeah, okay, granted.
And Yes, sir. And also there is some new osteogenesis in the
Okay,
next
let's
stage,
go
which
to
I'll
that.
take.
So here's
So,
the
yes, sir.
bone formation.
So there inside that bone, there are these osteocytes. So new osteogenesis with osteoblastic rimming was there, I felt, sir. And
Okay, so let's stop on this. So we agree that it's a spindle cell proliferation, vaguely storiform. They're not really hyperchromatic. I'm not very concerned about malignancy at this stage. It is very fibrous, and then there is bone formation. So the first question I often ask myself is this just reactive bone, right? So this could be lesion, and this could be just a periosteal reaction or some sort of a reaction, non-specific bony reaction to the tumor and not a part of the tumor. And the way I do that is I look for an osteoblastic rimming. And I know you did talk of an osteoblastic rimming.
yes,
Typically, osteoblasts look like plasma cells, and we'll see some osteoblasts as we go along, right? They look very much like plasma cells with the nucleus on one side and the cytoplasm on the other. And to my eye, we're not quite seeing that. In fact, there is a flattened layer of cells. Now, it doesn't mean to say that these couldn't be osteoblasts, and maybe they are osteoblasts, but they are not the plump osteoblasts that you see with reactive bone. So if I'd seen plump osteoblasts lining this bone, I would have said, oh, it's just reactive bone. Okay, so let me ask you another question. Do you think this is normal cancellous or cortical bone? Or is this woven bone?
this I thought this was woven bone, sir. And also
Okay,
there are
so
these
very good. This is woven bone. But why do you think it is woven bone? All right,
there are
I'll give you a few things, tips, right? So woven bone does not have the parallel lamellae that mature lamella bone would have. Remember, lamella bone, whether it's cortical or cancellous, has parallel lamellae. If you look at this, and often if you crank your condenser down, you get those lamellae sort of amplified. In fact, I just discovered yesterday one of the best ways to identify lamellae is if you get a little air between the cover slip and the slide, it seems to enhance the lamellar formation. So, of course, you don't want your slides with air bubbles all over. But if you do get a slide with air bubbles there, you enhance the lamellae. So there's no lamella formation. In addition, it's very cellular, right? So there's a lot of osteocytes, and we know that
osteocytes
they're osteocytes because they're within bone, and
and
they're present in a
lacuna around
lacuna space.
it.
So two cellular. So it is woven bone, and so there are these fragments of woven bone, and there is this fibrous stroma. We don't think this is reactive bone. We don't think this is pre-existing lamella bone. We have to believe that this is part of the lesion. And when you look at this under low power, it does give you that sense that it is part of the lesion. But there are not very many of these bony trabeculae, right? So do you have a diagnosis in mind?
A fibroosseous lesion of a long bone,
Yeah.
and based on the age now that patient is a child also, I'd like to consider one is non-osseous fibroma and os osteofibrous
Non-ossifying
dysplasia.
fibroma, you mean?
Yes, sir, because like there is that storiform pattern also,
Okay.
and it's
So you consider
but I don't
non-ossifying fibroma. Any other
that
diagnosis you might consider?
osteofibrous dysplasia, sir. One more
Osteofibrous dysplasia, okay. And a
known
third
to occur in
possibility?
long bones of children. So,
Yeah.
but the osteoblastic rimming also should usually is very like is absent in the non like osteofibrous dysplasia.
Okay.
So these two DDs I thought of.
Okay. And the
So
possibility, did you consider fibrous dysplasia?
That will have like very obvious osteoblastic rimming, no, sir.
I think you have them mixed up. So typically fibrous dysplasia does not have osteoblastic rimming, and osteofibrous dysplasia does have osteoblastic rimming.
Okay.
But there are very many other reasons for, that's all right. There are very many other reasons why this is not likely to be non-ossifying fibroma, right? NOF is typically a metaphyseal lesion, and it's typically intracortical with lots of marginal sclerosis. So radiologically, that would be very, very different. Non-ossifying fibroma, but its very name is is not ossifying, right? So you don't see bone in a non-ossifying fibroma. Osteofibrous dysplasia is mostly found in the tibia and the fibula, right? So that's a slightly different entity, not generally found in the femur. This is actually fibrous dysplasia. So this is quite typical for fibrous dysplasia. You see this very bland stroma, right? Spindle-shaped cells, virtually no atypia. And then you have these trabeculae of bone without very much osteoblastic rimming. Although I must tell you that occasionally with fibrous dysplasia, you will see osteoblastic rimming. And so it's not a hard and fast rule. I think the imaging here was very helpful. That ground glass appearance is very, very typical. There is just one. Is there anything malignant that you might consider? So the only malignant thing, sorry.
Maybe a low-grade fibrosarcomas.
Well, there's bone formation, right? So it would be a low-grade osteosarcoma, correct? Right. So there is a low-grade intramedullary osteosarcoma that you could potentially see. I've never seen a low-grade osteosarcoma this low-grade. So typically you'll have some level of atypia. The radiologist will give you some sort of a sense that they're probably dealing with an aggressive process. And this age would be an unusual one for a low-grade central osteosarcoma. There is some immunohistochemistry that you can do in some cases, and we certainly do it. You can also sequence this tumor. So what is the mutation that what you find in fibrous dysplasia? Does anyone know? So you got a GNAS mutation in fibrous dysplasia, and for a well-differentiated osteosarcoma, they tend to have MDM2 amplification. And so you could do immunohistochemistry or you could do FISH. Talking about MDM2, there's a lovely review in the Journal of Clinical Pathology on the basics of MDM2. I saw Ashwati's name pop up somewhere here. So she was rotating at the TMH when I visited, and that's where I connected with her. And then we wrote this very nice review in the JCP on the basics, and there's an accompanying video as well. So this is just fibrous dysplasia, right? And I think the final thing I wanted to point out is this is often, you see this often in fibrous dysplasia. I don't know whether you see these little strips of collagen connecting the bone with the underlying connected with the neoplasm. These actually resemble Sharpie's fibers, and so you often see this. I don't believe it's truly diagnostically helpful, but it's just one of these interesting things to observe. So these are sort of Sharpie-like fibers. Sharpie's fibers typically connect the periosteum to the underlying bone, and that's essentially what's happening here, right? So you have this connection between the underlying bone and the neoplasm. So just a classic example of fibrous dysplasia.
Sir, I have a small comment to make.
Yes, go ahead, Manish.
So Sharmila, your diagnosis as far as the pathology is concerned was quite correct in terms of you have diagnosed it as a fibro-osseous lesion.
Yes.
Okay. So problem is when you sign out the report, because it is not fitting into the radiology, your differentials. So that is where you should remember the common locations and the age of the patient. The differentials according to the location as well as the age, because of NOF will be a cortical lesion, as Dr. Vikram has already pointed. Osteofibrous dysplasia usually appears in the tibial anterior cortex. So that is also more or less a cortical lesion. Your diagnosis was correct, it's a fibro-osseous, but you have to see whether it's a medullary lesion versus a cortical. So there your differential changes completely, and then you would have been much more closer to your diagnosis than what you were. Your reading of pathology was excellent, so I think you should remember some differentials according to the radiology. That will be useful.
Thank you, sir.
Thank you, Manish. That was very helpful. I'll add to the audience in the room that Sharmila did not have access to those films beforehand, so I sort of surprised her with those images. So great discussion, Sharmila. Thank you.
Sir.
All right. So who's doing case 2?
That's me again.
Okay. So here again, I'm going to surprise you with this radiology. I forget what the history I gave you. I made it up, obviously.
18-year-old male humorist. lesion.
No, this is tibia, not humerus, and this is not 18
Yes.
for sure.
Again, it's not the
Much
epiphyse.
younger. Yes.
There's no occlusion.
So open plate again.
It's
Yeah.
a
So you can say
metaphyseal lesion.
perfect. Yeah.
And the delineation between normal and the lesion is there, sir. I'm able to see the delineation. And as far as the pattern of infiltration looks like there's some kind of a moth-eaten pattern.
Agree.
So it's probably
Guess you're breaking up, Sharmila. So it's a moth-eaten pattern, right?
moth-eaten pattern or like matrix.
Can't hear Sharmila well, I guess.
I think she's probably has some bad internet. Why don't you complete this,
Am I
Manish?
Yeah.
audible
So
now?
Oh, there
yeah,
she
you are
is.
audible. Yeah. Yeah. Go ahead, Sharmila.
Yes, sir. So metaphyseal diaphyseal lesion showing a moth-eaten kind of pattern. So I'm thinking could be
No, no.
radiologically.
No. You have not mentioned the second discriminator, which is the periosteal reaction. Can you see a periosteal reaction?
Yes, sir.
Where it is on the posterior, you can see an interrupted periosteal reaction. So there are two discriminators. Always remember pattern of destruction and periosteal reaction.
Okay, sir.
Okay. And does this lesion have a matrix?
Looks like osteoid matrix is there.
Yes. So aggressive lesion with periosteal reaction with osteoid matrix, I think your diagnosis is before you see the slides. You have the diagnosis in a young age.
Osteosarcoma.
Yeah. So if you don't see an osteosarcoma, then you should ask for a repeat biopsy, then anything else. Yeah.
So Sharmila, you have your diagnosis, but you want to describe the slides?
There are multiple cores on low power, and on going to high power, I saw that they were both. First, there is this abundant malignant osteoid deposition that we can see.
Hey, I'm going to stop you. So why do you think this is malignant? I would argue, and I'm just going to put a
Yes,
spanner
sir.
in the works here, that these cells don't look particularly atypical to me, right?
They
They
look quite bland, in fact.
Exactly.
Very low grade.
It's not overtly malignant, right? I agree with the bone deposition, right? So it looks pink. It's almost actually forming these reversal lines. This is something that you typically don't see very much of in the diagnosis we were talking about osteosarcomas. Generally, you see woven bone without these reversal lines. I mean, reversal lines are, we can talk a little more about reversal lines, but there's something that you typically see in Paget's disease.
Paget's disease. Pagetoids.
It's referred to as pagetoid distribution as well. It's something that you see with a reactive process, so it's unusual. So firstly, it's bone, but it's kind of deposited in this sort of these hunks of bone, and then it has these sort of reversal lines and very, very bland nuclei. But there is something here on low power, and I think the next power as well, that defines this as an osteosarcoma. What do you think I'm trying to get at? So I think this image is probably the most helpful. This is infiltration. So let's talk about this bone. Do you see this? You see the lamellae here,
Yes.
right?
Yes.
This is lamella bone. This is native bone. This is the host bone. This is the tumor. This stuff is infiltrating native bone. And you can see that it's, remember when we talked on Tuesday, we talked about, a biopsy causing artifactual pattern of infiltration. This is true infiltration because you can see this neoplastic bone is stuck on this side, this neoplastic bone is stuck on this side. So essentially you have neoplastic bone on three sides of normal bony trabeculae. And I know it's normal bone because it's lamellar, right? This is infiltration. So even though this tumor is very, very well differentiated, right? And it looks very, very low grade, it is an osteosarcoma. Makes sense? So you could look at these individual cells and say, oh my God, this is not malignant. But there are two things that are sort of support the diagnosis of malignancy here. One is the radiologic image, and two is the fact that it's infiltrated. So this is a very sclerotic osteosarcoma, and this is what is referred to as a phenomenon of normalization, right?
Of cells.
Somebody was listening to me on Tuesday. Yay! So normalization is when you have a lot of sclerotic bone, the neoplastic cells start looking less malignant. So the point I was trying to make in this case is that some osteosarcomas can have very, very, very bland looking cells, particularly those osteosarcomas. You know, there's a whole class of osteosarcomas that are very bland, and that's parosteal and an intramedullary, well differentiated osteosarcoma. But then there are also high-grade osteosarcomas that can start looking low-grade because of this normalization phenomenon. So this is not a grade 1 osteosarcoma. Remember, grade 1 osteosarcomas generally do not get chemotherapy. This is actually a high-grade osteosarcoma with very bland nuclei because of normalization. And the way you recognize it, and the rule is very simple, a neoplasm, a bony neoplasm that infiltrates adjacent host bone is osteosarcoma until proved otherwise, regardless of the degree of atopia. So pay particular importance to the infiltration. It is one of the features that will help you. And for the orthopedic surgeons, you know, we ask her often when we have trouble, particularly when we are trying to distinguish an osteoblastoma from an osteosarcoma, we'll often ask our orthopedic surgeons to try and scrape out the interface between the bone and the adjacent tumor, and that's where you'll see it. So it's a beautiful case of a very sclerotic osteosarcoma. Here you see it again. So this is lamella bone, see that in the center? You can see these beautiful lamellae. If I could crank the condenser down, it would be much more prominent. But fortunately, a histology artifact has made it rather prominent for you. And then you can see tumor on both sides of that. But you can again see how incredibly bland it is. So these are all osteosarcoma cells, but when they've got trapped in that bone, they've gotten normalized. Here's another picture of that. Notice the beautiful lamellae. This is normal bone. That's neoplastic bone. That's neoplastic bone. And here's another picture. Normal bone, normal bone. And then there's this neoplastic bone, and these are the neoplastic cells in there. So this was a very osteoblastic osteosarcoma. Manish, you have any comments on this?
Just a small comment, like in the sense that what the image you have shown was of CT scan. Just a word of caution, like the plane, what I have described as a zone of transition, periosteal reaction, are on plain radiographs. So this is a CT image. It doesn't look like a plain radiograph.
Yeah.
Just a word of, because all malignant bone tumors also will have a narrow zone of transition on MR. So the zone of transition, periostitis, is mainly described on a plain radiograph rather than a CT, or because these are much more, like they are much more deeper images. They define the quality in a much better way. So never comment on a CT image. Always ask for a plain radiograph when you are commenting about zone of transition or periosteal reactions. Yeah.
Thank you, Manish, and very nicely done, Sharmila.
Yes.
All right, so we're moving on to case 3.
So Gunjan will be taking this case.
Oh, go ahead.
Hello, everyone. I was given the history of a 14-year-old male having a femur lesion.
That history matches, or did I make it up again?
I think a little bit, sir.
I can still see it's not the epiphysis is not.
I think by 5-6 years only now.
Okay. So this is the femur only, but
Yeah.
the lesion is in the metaphysis, basically metaphysis diaphysis junction, I think.
Yeah.
And
So what
I
is
can
the white line below it? So what is this line? What is this? Yeah, which Dr. Vikram is pointing. What is this part of a bone?
this is basically the medial part of the bone, the cortex.
Medial cortex. So lesion
Cortex.
is not in the metaphysis. It's in the
Yeah.
cortex.
Okay,
Just
it's in the
wanted to
cortex.
highlight. Yeah.
Okay. So it's a cortical lesion, and there is a lucency in the center, and I
Yeah.
can see a sclerotic rimming at the periphery of
Yeah.
the lesion,
Yeah,
and I can see a clear demarcation from the normal bone as well. And
perfect. And any periosteal reaction?
I cannot see any periosteal reaction in this lesion.
So what do you feel, benign or malignant?
I think this is a benign lesion,
Benign lesion, young age, cortical. Okay.
cortical lesion. Yeah.
So what differentials you can think of? Benign, young age, cortical.
Uh, Osteoid osteoma. It
Yeah,
is in the
osteoidostoma is one.
lung.
Yeah. But do
Yes,
you see a
as well
matrix in
as
osteoidostoma? You see something?
osteoid osteoma. In the center, we can have a mineralized matrix.
Yes. Yeah. We are not able to appreciate here, but we
Yeah,
can have a
yeah.
mineralized matrix. And what else?
The similar one is osteoblastoma. The difference being that it is a little more locally aggressive, and the size difference basically is
Agree.
usually more than 2 centimeter in dimension.
The nidus, the lytic area is more than 2 centimeters.
Lytic area is translucent area is more than 2 centimeter in osteoblastoma.
Yes.
Good, good. And that's an excellent discussion. And they typically are young adults and teenagers who present with pain, right?
Yes.
And it's responds beautifully to NSAIDs.
Yes.
So let's take a look at the histology, right? So on LOPA, there's, this is typical of biopsies. They'll sort of give you this. This is a particularly fragmented biopsy, but it's not
Yes.
uncommon to be fragmented. But I wanted to stop here and see what you thought of this image and what this stuff is.
Basically, in this image, I was able to see the normal, mature lamellated bone fragments.
Very good. So this is lamellar bone, right? So this is
Yeah.
lamellar bone because you can see these parallel lamellae. You can see osteocytes here. Why aren't there any nuclei here? What's going on? Right? So it's again
This is
lamellar bone, and there are no nuclei in it. Is this dead bone?
I
Because
think
that's one reason for the
sclerosed.
osteocytes
This is
disappearing.
getting sclerosed like the bone.
The most common reason for osteocytes disappearing is over decalcification. So this lay in decal solution for a little too long, the nuclei disappear. This isn't unlike it's very unlikely to be dead bone because dead bone has that rat-eaten appearance typically. Spicules of dead bone, particularly those that come out from osteomyelitis, typically have a rat-eaten appearance. This doesn't have that rat-eaten appearance.
Yeah.
So one assumes that this is just over decalcified bone. What do you think of this stuff, this material here between? It seems like there's shreds of bone, right?
Yeah. Yes, sir.
So this is the kind of bone that you get when the radiologists drill through the bone. This is where we refer to this as bone dust. And the reason I sort of emphasize this is that people occasionally, the radiologists will not quite capture the nidus of an osteoma, and instead, remember, there's this very sclerotic reaction around an osteoma, so it's
Yes.
tough to get in there. So occasionally they just get the periphery, and people get trapped into calling this an osteoma. But remember, this is just bone dust, and this is just, as you pointed out, just cortical bone, which is a lamellar cortical bone. All right, so now I think we are in the lesion, right?
Yes, sir.
So let me just flip through images if most people haven't seen these images. So I'll flip through these images. Here's lesion, higher power, very high power, right? So let's see, Gunjan, why don't you talk us through this?
So in this image, I think this is basically a foci of nidus because it was very well circumscribed and it had the interlinking of the woven bone, but it was like having a lot of mineralization. So I thought this is a nidus with the periphery having the normal laminated bone.
There's extensive bone deposition, almost forming a sheet-like appearance, right? It's not the usual appearance for an osteoid osteoma, but occasionally you see the sheet-like osteoid deposition. I couldn't say whether it's mineralized or not because this is a decalcified sample. It could have been mineralized and now it's completely decalcified. Clearly, given the fact that it looks so pink, somebody's been somebody's been a little too generous with their decalcification procedure. But this is a little more typical, right?
Yeah,
Now,
this is a bit more
so
typical.
let's
So I
go into
think,
one higher power, and why don't you describe this for us?
yes, So in this, I was able to see the haphazard arrangement, the intertrabecular, the anastomosis between the trabeculae in a haphazard manner of the woven bone, basically, these ones. And along with
So
their,
it's woven bone again because it's very cellular and there's no lamellar
yes,
architecture, right?
I could see a very focal osteoblastic rimming. I could not see the proper osteoblastic rimming around these trabeculae.
Right.
But
So osteoblasts again for the audience should look like
plasma
plasmacytoid-like cells,
cells.
and they're very hard to see. Instead, what you have is some sort of loose vascularized stroma and sheets of bone production with very, very benign-looking osteocytes. And I didn't mean to do this, but it's a sort of a nice contrast with the osteosarcoma, right? Um, there is, at least not on this biopsy, but we don't really see any infiltration of pre-existing bone.
Yes, sir.
We have radiology helping us because it looks very banal. We have that classical history that's helping us. So this cannot be one of those normalized, very sclerotic osteosarcoma. So I agree with your diagnosis. This is a fairly typical osteoid osteoma. Again, an intracortical location, rarely epiphyseal, and some actually when it occurs in the epiphyseal bone, it sort of presents like arthritis, and you can have things like effusions. It's one of these things that is often misdiagnosed, particularly by physicians who lack the experience and non-orthopedic surgeons. Typically the way they're treated is in the old days they would do en bloc resections, and occasionally for spinal osteoid osteomas they might still do it, particularly when they can't treat it in any other way. But the most common way to treat it, at least I'm sure this is how they're all treated now, is you just burn them, right? So you ablate them using
Radiofrequency
thermal
ablation.
energy. And typically what our radiologists will do is they'll get a little biopsy and then just burn them off. And that treatment seems to be very, very curative. Um,
Yes, sir.
any thoughts, Manish, on this?
I think you have covered everything, sir, including the treatment. Yeah.
Oh, Gunjan, let's talk a little bit about the genetics of,
Yes, sir.
again,
So,
I will tell you that this is really not relevant, right? So many bone tumors, and I think we were talking about this with Dr. Borges yesterday. Most tumors, the diagnosis really is an H&E diagnosis. I suspect that's sort of going to change with the newer generation that is so used to genetics and immunohistochemistry. But the way I was taught bone pathology, it's primarily an H&E diagnosis. But like I said, I think your generation is going to see so much. Genetics is going to have such a big influence on you guys that you guys are going to reach out to genetics far before my generation would. So unfortunately, I am of an older generation. I just have to accept that now. Yes, go ahead, Gunjan. You were
so we
telling us about the
see in
genetics.
these cases, yeah, there is a FOS gene rearrangement that is seen, and
Yeah,
FOS B gene as well rearrangement. So it is actually it is detected at the protein level. We use basically anti-FOS for the protein level IHC detection, and by that we detect it.
correct. So far, immunohistochemistry could be helpful. We've certainly tried it, and it generally seems to work, right? Um, let's talk about case
Sir, I
four.
have a doubt. I'm sorry, I have a doubt.
Yes, yes,
Yeah,
please go
so
ahead.
in one of the image that was there in which we talked about the overcalcification, the last image, I think,
This one?
escape beyond that.
Stop me when you see it.
Yeah, not this.
First image?
This one, so this one only. Sir, in this image, in the rightmost lower area, is this a nerve bundle that we see?
This one?
Yeah, sir.
I think it's a vessel. It almost looks the size of a nutrient artery, which is about where the nutrient artery enters, or one of the branches of the nutrient artery. It's a vessel, actually. I think it's tangentially cut and seems as if it's sort of completely. The lumen looks almost obliterated, doesn't it? But it's not
So
a nerve.
intracapsular vessels are very prominent in the kids. So
Okay.
because
Okay.
this is the neck area, femoral neck, and the vessels are
Yeah.
on the surface below the capsule. So I think this could be one of that vessel, which are big and which supplies the femoral head.
Okay.
Yeah.
Because in
Fortunate.
one of the books, I saw that we can also use ancillary studies and using S100 because in S osteoid osteoma we can have no filaments in between the
I've heard that. Yeah. I've never used that immunohistochemistry, but that's probably why they have so much pain, right?
yeah,
Uh,
this one.
but I've never used that to actually make a diagnosis. Again, it's a classic H&E diagnosis. It's very seldom that we have problems with osteoid osteomas.
Thank you so
Uh,
much.
thanks. Are you discussing the next case or is someone else?
No,
So
someone else.
Raghav is discussing the next case.
Okay, go ahead.
There are expansive growth on the posterior element of the spine
Okay, so
with a,
important, posterior element. Okay.
with a different level of mineralization.
Perfect. Yeah.
Sclerotic, right? Heavily mineralized.
So
What do you think? Or do you want help in interpreting this image?
Sir,
I have no shame in asking my radiologist for help because, or my surgeon for help because I don't know. I know stuff under the microscope. Beyond the microscope, my knowledge is somewhat limited.
sir, according to site, it may be osteoblastoma
Okay.
or osteoblastoma like osteosarcoma.
Okay. So one or the other, right? So, do you want to call on Manish to help us?
So yes, so Raghavendra, no, yeah, sorry. Yeah. So it's a bone forming lesion. As you can see, you have nicely described bone forming, lytic, sclerotic, okay, but not causing too much of a soft tissue component,
Yes.
okay, and not causing too much of a cortical dissection. There is some cortical dissection as Dr. Vikram is pointing, but not a huge soft tissue mass associated with this lesion,
Yes.
okay. So a bone forming lesion which is not causing too much of a soft tissue component or a destruction in a posterior elements of spine, your first diagnosis is usually osteoblastoma. Yeah.
That is how it was interpreted. And
This kid is in his teens.
okay, hang on.
This was a vertebral body lesion. As you
Not
can
sure
see,
why
it's in
this.
fact
Let's skip this. Okay, so
Sir,
Raghavendra, you want to describe this?
section examines both multiple bits of tissue consist with light blue area, light blue dense cellular areas and bony fragments.
Okay, so let's try and
Thus,
decide whether this bone is
there are
part of a
lamellar bone
lesion. Sorry? Go
and
ahead.
highly dense cellular area in between the surrounding the bony trabecule.
So what do you think about this? This looks like lamella bone, correct? You have
Sir,
lamella bone on
there
this
is
side.
eosinophilic material in the background.
Yes. And there's lamella bone here, and this is that eosinophilic material.
What is it?
Why do you think it's bone? This part.
Sir, there are many osteocytes in.
True, there are some osteocytes, there's some lamellar structure, but the way it is deposited, right? So it's deposited in this sort of filigree pattern. It's sort of this irregular network of pink material that is very typical of bone formation. And in addition, it is mineralized, right? So it's not been over decalcified as in the previous sample. You see this blue material. What do you think of the cells lining the bone?
These are osteoblastic remain.
Yeah, so they look like osteoblasts, and this is what I was talking about. This
Cells
is
are
what typical
plasmacytoid and with eccentric nuclei and abundant eosinophilic cytoplasm.
Yeah, and you know, one of the things I've noticed about osteoblasts that differs from plasma cells, in fact, osteoblasts can have a little perinuclear half, just as plasma cells do. But notice how the nucleus almost, there's no cytoplasm lining the other side of this nucleus, right? It seems as if the nucleus, to my eye at least, is sort of being exuded or tossed out of the cell, right? So it's a very particular thing. And all the other thing I'll point out is osteoblasts seldom are seen outside the context of bone deposition. So osteoblasts almost always line bone, right? So they don't form big clusters except in perhaps aggressive osteoblastomas, and apparently that's a term that we are not supposed to use anymore. So the term aggressive osteoblastoma, if you've heard about it, you should forget about it. So this really does look like an osteoblastoma, correct? So what do you think this is? Is this, what's the other possibility? And I think you mentioned it. You said either this is an osteoblastoma or this is an osteoblastoma like osteosarcoma.
Sir, in another image, the tumor is infiltrating the pre-existing lamellar bone.
Yes, that is what it is, right? So, and what does that say to you that it's in when it's infiltrating lamellar bone? An osteosarcoma, right? So an osteoblastoma will not infiltrate lamellar bone. So this is what is referred to as an osteoblastoma like osteosarcoma. In fact, I'll lead you into a little secret. This was actually originally called an osteoblastoma. And you can see why they might have called it an osteoblastoma. This is what osteoblastomas look like. You get these chunks of bone lined by very, very prominent osteoblasts. And the osteoblasts look somewhat atypical, but I can promise you that some osteoblastomas, particularly what we used to call aggressive osteoblastomas, can look very plump and very, very juicy. So you can't make the distinction between an osteoblastoma and osteoblastoma like osteosarcoma based solely on the cytology of the cells. It is true that most osteoblastomas do not have this sort of lace-like deposition of osteoid. Generally, you see chunks of osteoid being deposited. So that lace-like pattern of is worrisome in this case. But the reason why this is an osteosarcoma is because the tumor is infiltrating lamellar bone. And I can't emphasize this enough. This is such a useful feature to distinguish between benign and malignant. And you have to be absolutely sure that the bone you're seeing or calling infiltrated is truly lamella. So you need to go down on high power and make sure that you're seeing these parallel lamellae. Crank the condenser up and down to make sure that it's lamellar bone. Once you're absolutely sure it's lamellar bone, then if you see tumor transgressing through that lamellar bone, that is malignancy. At that point, I don't particularly care what the radiologist tells me. Oh, and then the tumor should be stuck to the lamellar bone. You want to make sure that it's not sort of being pushed there during the surgical procedure. And at that point, I don't care what the radiologist tells me. That is diagnostic for an osteosarcoma. And in this case, of course, I couldn't share with you all of the films, et cetera, et cetera. It was a difficult challenge. So the radiologist was not very helpful. So he told me this could be an osteoblastoma, this could be an osteoblastoma like osteosarcoma. There was no soft tissue mass associated with this. It was extremely mineralized. And he told me, and it was a very good radiologist, and he told me there's almost no way I can tell the difference between the two. And at that point, I've seen something that is diagnostic for an osteosarcoma. I'm done, right? So that's sort of the interplay between the radiologist and the pathologist. There are sometimes where, the radiologist is not going to be certain. So you can't rely solely on your radiologist. They're very good, but there are times when they just don't have the features necessary for the distinction that we are really looking for. And again, you'll notice, again, you can do FOSB here. You could do immunohistochemistry or you could sequence it. But by and large, this is still a morphologic diagnosis. It is a highly challenging diagnosis. And I think all of us at some point in our lives, if you do enough cases, if you do enough referral cases, you will make the error. I don't know whether you've ever heard of this saying, but there are two kinds of gastrointestinal pathologists, one who has missed a gastric cancer, and the other half who will in the future miss a gastric cancer. So it's a little like that. This is a very, very challenging area. And if in your future practice, if you ever see one of these or suspect one of these, I think the best thing is to reach out to an expert on bone pathology. And even experts can be wrong. Not infrequently in the US, cases are traded from some big institutions. So typically they would be moved around from Mass General to a Memorial to the Mayo Clinic. And, often you'll find that you'd think that they'd all agree. Often even the experts don't agree, which really confuses the surgeon. So anyway,
So,
osteoblastoma like
sir, I
osteosarcoma.
have a comment here.
Yes, go ahead.
So the challenge in diagnosing these tumors is not, sir, what you are seeing on pathology, is the way we do our biopsy. Because in osteosarcoma or in any bone tumor biopsy that we do, we always say that the extraosseous component of the tumor is equally representative of the tumor. So if we biopsy the soft tissue component or an extraosseous matrix of the tumor, we are not going to see the bone permeation by these osteoblasts or the malignant cells. So that is why very often the biopsy suggests a benign pathology, but when we resect or we curate, it shows that bone permeation. So, so that is the challenge actually in osteoblastoma like osteosarcoma, like the biopsy is many of the times appears benign because you don't see that permeation. That is what we have also faced many of the times. But when we do a curettage on the basis of biopsy, we see that permeation and then we say, oh no, what we have missed actually. So I don't know whether that bone permeation was your biopsy slide or whether it was a final curettage slide, but that is the
That was a
challenge that we
curettage,
face.
yes.
Yeah, so that is the problem, sir. We don't see that in biopsy.
Of course, yes.
Yeah,
I always reach out to my surgeon and tell them we want the periphery of the tumor, right? The interface is what we really want.
yes, sir.
I don't know how much you guys do it in Tata, but at least at Mass General, and I'm sort of continuing that that policy here. Uh, we would not only they would not only biopsy it, but when they go ahead and curate it, so if we tell them it's benign and radiologically it's benign, they'll curate it. But before, getting deep into curettage, we would freeze tumors. We would freeze everything.
Okay,
We freeze bone tumors frequently. It is a fallacy that you cannot freeze bone tumors. You cannot freeze cortical bone, yes, but you can freeze cancellous bone and you can freeze most bone tumors unless they are sort of an ivory-like osteosarcoma, and that has saved us on many occasions because at that point they might be able to get you interface. And not infrequently, we'll tell our surgeons, I'm not sure what this is. Stop at this point because you do not want to be curating an osteosarcoma.
agree, sir.
Um,
Yeah, that is the challenge.
and so, but you got to have a lot of experience to do that. But yes, very good comments, Manish. Thank you.
Vikram,
Yes, go ahead.
one of the things that is very helpful, particularly if you're doing needle core biopsies, is to freeze at least a portion of it to make certain that this is representative, you know? Because
Yes, so
yes,
that interestingly enough, not everyone practices. So at the Mass General, we used to do that all the time. We used to do that for triage as well as for make sure that it is
yeah,
representative.
well,
When I came to the
yeah,
BI, no one freezes these core
it's
biopsies
really
anymore.
very useful, and that as long as I was in Tata Hospital, that's what we would do with these needle core biopsies because it didn't make sense that you did this needle core biopsy and then after processing it and 2 or 3 days later you say you haven't got representative material. So I think that's one very good sort of place for freezing tumors. And like you said, unless it's dense cortical or dense bone, you can freeze them and you get a very good
Yeah.
idea of what's going on. Anyway, thank you.
Oh, that's very helpful. Thanks. So again, I've given you a completely wrong history. So let's just assume that it's a much younger patient, and it's in the FEMA. Who's discussing this case? Case
Manish
number
will be
5.
taking the case.
Okay. Give this bone radiology a shot.
Hello, am I audible, sir?
Very much
Yes,
so.
yes.
Go ahead.
Sir, I was given 34 female tibial lesion, but it looks
Well,
like
ignore that history. It's a much younger patient, and it's in the FEMA.
uh, Sir, there is a fracture there,
Yeah.
which includes the cortex as well as the medullary part of the bone.
So Manish, if I want to correct you here, so this is the second part where you have to tell what is the lesion doing to the bone. The first question is where is the lesion? Okay, so do not jump on the fracture straight away because that is very obvious that you can see. Okay, do not miss the most important part here. It's a diaphyseal lesion.
Diaphyseal lesion, yes.
Okay, so I think if you go in a sequence, it always helps. What is the zone of transition always helps. Okay.
Yes,
So
sir.
I understand there's a fracture and that is the most obvious thing that you see here, but I think don't jump the sequence. Go, where is the lesion? What is the lesion doing to the bone? What is the bone response? Then anything suggestive of histology, which is the matrix. If you go in this sequence, I think you will be able to reach a diagnosis.
Hey guys, just give me 1 second. Manish, why don't you continue with the
Yeah,
discussion
yeah,
on
I'll
the bone
continue. I'll
on
continue with
the
the radiology.
film?
Yes,
I'll be back in a minute.
yes, Manish, go ahead. It's an immature skeleton. That is the first thing. It's a diaphyseal lesion. Yeah, yeah. So are you able to mark the lesion, whether it's a narrow zone of transition or a wide zone of transition?
So there is wide zone of
Wide
transitions.
zone, perfect. Because we are not able to mark it cleanly, है ना? We are not able to draw a pencil line कि that's a normal bone and that's a abnormal bone. This looks like a permeative lesion in the
Yes,
diaphysis.
diaphyseal.
Okay, and it is causing a pathological fracture. So any periosteal reaction that you can appreciate here? No, I can't see any periosteal reaction. Okay, and any matrix in this lesion?
Sir, there is some matrix in the upper part of some matrix deposition in there where there is fracture line is there.
So I can't see any matrix actually, but yes, sometimes in one view it becomes little confusing because of the overlap of the fragments. Okay, so you should always have a two views, which might not be possible in a case of a fracture. Okay, because the patient is in a pain, but it is always good to have two views of the bone. So now this creates a confusion because now you have a lesion which has a wide zone but no periosteal reaction, which I have not told you. Like we have told you two scenarios: narrow zone of transition, no periosteal reaction; wide zone with periosteal reactions. So these comes in borderline when you have a wide zone but no significant periosteal reaction. Okay, so then you are thinking of some locally aggressive pathology, but you are not sure whether you are dealing with a benign versus a malignant situation. So in these cases, a further imaging can obviously help you, like I'm doing an MRI or a CT scan with that. But yes, it becomes a challenge when you see a wide zone of transition but no periosteal reactions. Okay.
Yes, sir.
Have we decided what this is, benign or malignant? Or is this
So it is in a gray area, sir. It has a wide zone of transition, no periosteal reaction, so it becomes a gray area. We are not able to call benign or malignant. So we'll call it as a locally aggressive neoplasm, and a further imaging with MRI will help us to differentiate it
right,
better.
right. And so this is a situation where you at least we used to frequently get frozens, right? So you know, is there an underlying lesion related to this fracture? And this is where it's important to be able to recognize a malignant neoplasm at the time of frozen, because you don't want to be putting a rod in a femur, and I've seen this happen, and it's an awful process. You don't want to be putting a rod of a femur into a malignant bone tumor. Um, so you want to continue?
Sir, this is on low power microscopy. There is a highly eosinophilic area towards the left side.
Let's actually just
On the
get to the
right side,
money, right? This is the money, right?
yes.
So
So
what
there
do you
is
think this material is?
sir, there are osteoid depositions are there in
Very good. And why is it osteoid?
sir, because there is osteoblasts there are osteoblasts near these osteoid matrix.
let's come to that. So I think this is osteoid, and I think one of the issues often you'll bump into, and sometimes it's impossible to tell, is this collagen, right? So collagen can look very pink as well, or is this osteoid? Now, if it's mineralized, and I think you get a sense that this is a little bit mineralized because it looks bluish, that helps make
Yes.
this osteoid. But I think even more importantly, collagen, fibrous tissue is never laid out in this fashion. You see this sort of filigree sort of
Lace
network.
like, sir. Lace like, arrangements of osteoids like that.
Lace-like, yeah, that's the buzzword that is often used. And when it's lace-like, it tells you two things. One is it tells you that it is bone or osteoid. I often use the word bone instead of osteoid and relate it to osteosarcomas. I know some people use the word osteoid. I think the word bone was drilled into me when I wrote a paper. I forget which paper it was, but the senior orthopedic pathologist on that paper kept replacing every time I said osteoid, he'd strike it out and say bone. And after that, it sort of stuck in my head. So I'm going to call this bone. So it's the lace-like bone. Sort of tells you two things. One, it is bone; it's not collagen, and that can be good. That could be a big problem because remember, the diagnosis of an osteosarcoma requires the presence of bone. And the other thing is lace-like deposition, you seldom see it in a reactive process. I'd never say never, but generally when you see lace-like pattern, you're probably dealing with a malignant process. And the diagnosis of an osteosarcoma requires two things, right? Bone deposition, and that bone has to be surrounded by neoplastic cells. So, Manish, are you convinced that this is malignant, the neoplastic cells?
So osteoblasts are highly pleomorphic.
Careful with the word osteoblast. When you say osteoblasts, you're referring to a benign cell. You're referring to the cell that I showed you in the last case, those plasmacytoid cells. I don't see classic osteoblasts here, right? So I would refer to these as neoplastic cells and not osteoblasts.
Pleomorphic neoplastic cells are there.
Yeah. So do you have a diagnosis?
That is osteosarcomas. There is
It's a
less.
classic osteosarcoma. And the only reason I wanted to show you this is to demonstrate this sort of lace-like network of collagen, of osteoid, forgive me, and and the fact that occasionally it can be very hard to tell between collagen, fibrous tissue, and osteoid. And I mean, I think anyone who has received even the slightest bit of training would know that these are overtly malignant cells. So this is a very straightforward osteosarcoma. And here's another beautiful image of that lace-like deposition of osteoids surrounded by these very, very malignant looking cells. There's a lot more pictures, I guess I gave you. Manish, any comments? I mean, you guys probably see a lot of osteosarcs.
So not so straightforward for a surgeon or a radiologist, but yes, definitely look aggressive. So we cannot call it benign on radiology. That is what I have told Manish. So that is where we start, and then the pathology helps in this.
Yeah, Manish, would you have been able to make a diagnosis of osteosarcoma on this radiology?
Ma'am, it
No.
was
Looks
not
like a
bone.
Ewing. Could look
Yeah,
like
yeah.
a Ewing.
So definitely, ma'am, it was in a gray area. It's an aggressive bone neoplasm, but no osteoid formation on X-ray. So I
That's
will
right.
not call it osteosarcoma.
Okay.
So case 6, who's describing case 6?
Anita will describe the case.
Yes. So in this radiograph, I can see it's a metaphyseal lesion. Is it audible? Am I audible, sir?
Go ahead. Yes.
Go ahead, Anita.
It's a metaphyseal lesion. And yes, there is periosteal reaction there.
Yeah.
Mineralization rather
Yes,
than a
the mineralized
periosteal
mark,
reaction,
yes.
right?
So Anita, I think in
Mineralization
this
on
case,
both sides actually.
Sir?
yeah. So in this case, because it's only a one view, I think you are getting a little confused. But the pathology specimen was very useful here because this lesion is not in the bone. It's not in the metaphysis because you are seeing just an overlap of the lesion.
Okay.
So, and this is not a periosteal reaction, because periosteal reaction is the periosteal new bone deposition. This is a dense bone which is there, which is surrounding.
There is a mineralized mass.
Yeah, this is a mineralized mass. Maybe sometimes you see a mineralized soft tissue component, a densely mineralized soft tissue component of a malignant bone tumor. But this
Okay.
looks like the lesion rather than a periosteal reaction, because you can see that the periosteum is not lifting here.
Okay. Okay, sir. So,
It's a mature skeleton. Okay, this is a very tricky image because you see a lesion in, if you can see through the bone, you can see a lesion on the back side. Okay, on
okay.
the posterior, on the anterior, plus you can see the lesion through the medulla also on the other side. So this looks to me more like a surface lesion with a very dense bone formation in a
Okay.
mature skeleton.
So it could be a
So
mass
in the
attached to
in
the
this case, a cross-sectional imaging is very useful because that differentiates a surface versus a medullary lesion, and that is what the pathology specimen has held on.
Right. So you want to describe this?
Yeah. It looks like a mass attached to the surface of the bone. I mean, surface of the distal femur. Yeah.
Optics. Optical.
I think this is this wasn't a gross image of this particular case, but I think look at the date. It's 1992. I think many of you guys weren't even born then, I suspect, right? But it's a nice picture because
There is no medullary involvement.
yeah, there's no medullary involved. The cortex looks intact, and there is this sort of surface, purely surface lesion. So you want to describe these slides for me? So I'll flip through the slides really quickly,
Okay.
just so that the audience has a sense of what they're going to be seeing, right? Okay, so let's start from the beginning. So what's this? Let me just direct you in the interest of time. What did you think this blue stuff on the surface was?
Cartilage.
So there's cartilage, and below that there's bone, right? So
Bone,
all
yes.
of these are bony trabeculae. It looks very dense, very similar to what we saw on the radiology. There's again the cartilage, there's bone, thick seams of bone. Let's take a higher look at the cartilage, and you can see it's very, very cellular cartilage, right? So you're thinking, and it's clearly hyaline cartilage. It looks quite cellular. The cellularity should confuse us, but there's no way I'm going to be able to call this osteosarcoma. Sorry, apologies, chondrosarcoma based on this cartilage, right? So the cartilage is doing something, but it's not telling me a whole lot. And then there are these thick seams of bone, right? Thick trabeculae of bone. Did you think this was woven bone or lamella bone? The bone
This is
itself.
woven bone.
Sorry?
It's a woven bone.
Yeah, it's sort of actually interestingly enough, if you look carefully enough, you do see some lamellae. So it's sort of this mix between lamellar and woven bone. It looks awfully mature, right? It certainly doesn't look like lace-like osteoid that we saw in that osteosarcoma. So clearly there's bone. There's no osteoblastic rimming, so we know that it's not a reactive bone. And then what's happening between the what's happening in the spaces between the trabeculae? What did you think of the atypia here?
There's atypia, there's nuclear atypia there.
Yeah, but the atypia, you'd agree, is very muted atypia. It isn't like obvious when you look at this. And I didn't give you too many pictures, but it looks quite bland to me, except that one cell that I showed you on high power. That cell really looks ugly, but the other cells don't look so bad. And then there was another area that I've showed you. This
Yes.
area, again, there is a cartilaginous cap, but suddenly the trabeculae, this is normal cancellous bone.
Yes.
The trabeculae seem to be separated out, and now you're seeing a slightly more cellular tumor. What do you think of this now?
Dedifferentiation.
Yeah, so now this looks high grade, right? Overtly malignant. So much of the tumor is that well differentiated, and now this is very, very ugly looking, and it's clearly infiltrating. And as you probably, this is the diagnosis you came up with, right?
Yes,
A
sir.
dedifferentiated parosteal osteosarcoma. All right, so I have a little video that might play. Let's see if it plays.
You like tape and I like potato, you like tomato, and I like tomato, potato, potato, tomato, tomato. Oh, let's call the whole thing off.
Here's a warning. This could be very hypocellular and bland, and it is so easy to dismiss this as a benign fibroosseous lesion. This is what I'm talking about. Imagine a biopsy from here, totally bland, but believe me, this is a parosteal osteosarcoma. That looks awfully like an osteochondroma, doesn't it? But talk to your radiologist. They'll talk you out of that diagnosis. This is a parosteal osteosarcoma. The cortex is often intact, but the tumor can infiltrate into the underlying medullary bone.
Okay, so parosteal osteosarcoma, not to be mistaken for a periosteal osteosarcoma, which is more cartilaginous. And often people get confused between those two terms. All right, I think we have 3 more cases. We'll go very quickly through them. Who saw case number 7?
Raghav. Raghav will take the case.
Do you have a diagnosis? Raghav?
Raghav?
Who is Raghav there?
Raghav is there. Raghav, please unmute
Okay.
yourself. I have sent your request. Please unmute.
Sorry, I didn't get that. Just go ahead and, why don't I just go ahead and talk about this? Did anyone think, this was sent to me, and this was one of my last cases I saw at Mass General, a young adult. It was sent to me as a osteosarcoma, and this was a subcutaneous mass. Does anyone have a diagnosis on this? Anyone who, so someone want to shout out a diagnosis, what they think this is? That's all right. This is, although there is a lot of bone, let me go. So there's a lot of bone, but if you look at the bone itself, you see actually there's a fair amount of osteoblastic rimming, right? See right here, that's osteoblastic rimming. Then that should have stopped you from making a diagnosis of an osteosarcoma. Osteosarcomas don't typically have this classic osteoblastic rimming. The low power appearance is very helpful as well. So the center of this lesion looks very immature, and the periphery looks like bone. But I think that the thing that confused the outside pathologists in this case is that it looks very cellular and sort of bluish at the periphery. And I'll show you those areas as well. So there are areas that look very much like fibrous dysplasia. This is sort of spindle cells that look like fibrous dysplasia. There's the reactive bone. That bone was mostly present in the periphery, and you can see that it is sort of lined by this osteoblastic rimming. This is the center of the lesion, and this is actually very, very scary. If you look at this, it almost looks as if there is vague osteoid deposition with these very immature cells. But remember, this was in the center of the lesion. And again, the center of the lesion, some of this may be bone, some of this may be just collagen. So it did look very scary, but this is actually just myositis ossificans. And I think the clue that this is myositis ossificans, there are many, many clues. One is extraskeletal osteosarcomas that are extremely uncommon. Before you think of an extraskeletal osteosarcoma, always think of myositis ossificans or even heterotopic bone formation. The other thing is the zonation phenomenon, and that's where things got a little confused in this case, you know. Typically, the bone is present only at the periphery, so the center of myositis ossificans is very immature, and the periphery tends to be more bone formation. And as you go out to the periphery, you get more and more mature bone. It got a little mixed up, I think, because of a tangential section. But if I would tell you that this is the center of the lesion and here's the periphery of the lesion, that zonation becomes very obvious. So that zonation is very helpful. And finally, when you see a prominent osteoblastic rimming, you shouldn't really be making a diagnosis of an osteosarcoma. We did send this for fusion, and I did that because the family was so anxious. They came all the way from Boston, from some Midwestern state, and as you can imagine, you know, it's a young child, and they've been told it's an osteosarcoma, and now I'm calling it benign. Anyway, it had the characteristic USP6 COL-A1 fusion. So this is just myositis ossificans that mimics a osteosarcoma. Case 8 was actually a classic osteoblastoma, and I sort of put this in there specifically to contrast it with that earlier osteoblastoma like osteosarcoma. This is again in the posterior arch, posterior elements, and I put this very low power picture here primarily because see how well circumscribed it is, and that's really what you want to see. This is the lesion here. You can see there's big chunks of osteoid. Again, look at that interface. It's such a clean interface. This is just reactive bone, which is sort of responding to that neoplasm. And then when you go on higher power, to tell you the truth, it does look a little scary, isn't it? If you look at these cells on high power, I wouldn't be able to tell the difference between this case, which is an osteoblastoma, and the osteoblastoma like osteosarcoma. So again, it's the infiltration. If there is one thing I want you to walk away from that and never to forget, and it is this, that infiltration of pre-existing lamellar bone is diagnostic and is a very helpful feature in bone pathology. So beautiful osteoblast, big chunks of osteoid here. And areas of this osteoblastoma were very almost ivory-like, so solid sheets of bone deposition. But again, these are few osteoclast-type giant cells and very prominent osteoblasts. So some people would call this a aggressive osteoblastoma, but like I said, that term is frowned upon. And forget these notes. I'm not sure. I'm trying to correlate this with. I do have these cases, actually, whole slide scans of these cases, and maybe I'll send that link across to you guys so you can see the entire case as well after this conference. Case 9, since we have a few minutes, does someone want to describe case 9?
You know, for these osteoblastomas, Vikram, can I just make a comment? And maybe if you could go back to one or two of your sections.
Yeah.
Yeah. You notice the intense vascularity that you see in an osteoblastoma. You see these capillary-sized vessels, and it's seen so well in this osteoblastoma. I find that quite helpful, actually.
Yes, I agree that.
Yeah, it's and of course these thick or large areas of dense bone formation. Don't really see that in osteosarcomas unless
It would be very unusual.
yes. Sorry, go ahead.
No, that's very helpful. Yeah, it's very prominent vascularity, and that it shares that characteristic with an osteoid osteoma. And that distinction, interestingly, between osteoid osteoma and osteoblastoma is entirely arbitrary, right? That 2 centimeter rule.
That's right.
They have the same genetics, so perhaps it's time to change that nomenclature as well.
Case
And
9,
does someone want to describe case 9? Is there anyone?
Yes, sir. So it's a radiographic image of a long bone, which is looks
Karishma,
skeletally
right?
immature. Yes, sir.
Okay, go ahead. Yeah.
So it's a radiographic image of a long bone, which appears to be
The
skeletally
tibia.
immature, and the lesion is in the
Very young
diaphyseal.
child. Yeah, very young child.
Yeah, and it's a diaphyseal lesion, probably arising from the cortex with the periosteal reaction.
Where is the periosteal reaction, Karishma? So that is, we'll not call that as a periosteal. It's just a lifting of the. It's actually splitting the cortex in between. It's in the cortex. It's an intracortical lesion. So we can see the cortex on both sides of the lesion.
So there is a radiolucency which is in the center with the sclerosis in the periphery.
Perfect. So it's a lytic sclerotic lesion. And it is very clearly defined from the normal bone. It's cortical and no significant or no aggressive periosteal reaction. That is what you can see.
Yes.
Yeah, in a very young child, because if you see this tibia, this is a very small tibia. This is in tibia, anterior cortex of the tibia. It's a very small, look like some 5 or 6-year-old child. You can see the length of the bone, just making a wild guess, because the tibialis and calcaneum also looks very small. So what do you feel? A cortical lesion in the tibia with some bowing also of the bone, whether benign or locally aggressive or malignant.
So it looks like
It's a gross
benign,
description.
but
It was in
locally
the
aggressive.
anterior cortex, and it had this sort of fleshy appearance. Yeah.
Yeah.
And here's the lesion. You can see, Karishma, it's very well demarcated. This is cortical bone. Here's the lesion. It's clearly fibroosseous, right? You want to describe what we're seeing here?
We can see a haphazard arrangement of these trabeculae woven bone, and we can see osteoblastic rimming as well.
Yes.
So these osteoblasts, they appear more plumper than the usual osteoblasts. And so there is more fibrovascular stroma. So in this, there is a...
Okay. I gave away the answer, but then go ahead. What were you going to say?
So there is mitosis.
Did you see mitotic activity in the spindle stroma?
So very less, only 1 cell.
And did you see any epithelial elements here? No. Okay. So, oh, sorry. What did I do now? Yeah, can I just? Oh no, I'm going to give you guys a seizure now. Sorry. I have this bad habit of moving to the end and then. So, what did you have a diagnosis? Karishma, while we go through this, don't look at the screen because it's going to blind you. Did you have a diagnosis?
So
it's a fibroosseous lesion? Great.
Yes, sir.
And what do you want to call it? So your differential is fibrous dysplasia, a very well differentiated osteosarcoma, which is probably very unlikely because it's so well circumscribed, osteofibrous dysplasia, and adamantinoma, right?
Yes, sir.
And so how are you going to tell the difference between all of these?
So in osteofibrous dysplasia, there will be prominent osteoblastic rimming.
Is here, right? We're seeing very prominent osteoblastic rimming.
Yes, sir. So in fibrous dysplasia, there'll be not that much prominent osteoblastic rimming. And sir,
And fibrous dysplasia would be an intramedullary lesion, not an intracortical lesion, correct?
yes, sir.
Yeah. And what about an adamantinoma? That's the other differential. So just in the interest of time, I'll move quickly. That was a very good discussion. Thank you, Karishma. So the differential diagnosis is osteofibrous dysplasia, characteristically in the tibia in kids in their teens or slightly younger. The differential diagnosis is a very well differentiated adamantinoma, where you just see a few clusters of epithelial cells. And the way we typically make this distinction, adamantinoma is a locally aggressive tumor, osteofibrous dysplasia is completely benign. Adamantinomas, there's two kinds of adamantinomas. There's the classic adamantinoma and the well-differentiated adenomantinoma. The well-differentiated adamantinoma tends to overlap with osteofibrous dysplasia, and the distinction being is in an adamantinoma, you'll see epithelial cell clusters. Sometimes they're hard to see on an H&E. We typically use immunohistochemistry to identify these rare clusters. Do you have anything to add, Manish, to that?
So this
The
case
management.
so this case radiologically was osteofibrous dysplasia. We would have just observed it because of a very young age. Yes, but for an adamantinoma or OFT-like adamantinoma, we have to resect with a clear margin. So that is the treatment of choice. We cannot curate an adamantinoma. That is first thing. And second thing in an adamantinoma that we should be aware is usually we always, as a surgeon, we biopsy the periphery of the lesion. But adamantinoma, we have to biopsy from the central, more lucent area because otherwise you will get only a normal looking osteofibrous area. So adamantinoma, usually we biopsy from the center of the lesion, the central lesion, because that is usually more representative as compared to the peripheral edge of the lesion. That is we should be aware of. So you should always ask for your surgeon as a pathology that where you have biopsied this lesion, because adamantinoma or like OFT like adamantinoma, it's an overlap of features. So if they have not targeted the right area, you will see only osteofibrous area, not anything which is suggestive of a malignancy.
Oh, that was very helpful. You guys will notice that Manish talks the language of pathologists, and that's sort of so important for not all surgeons do that, right? Not all surgeons speak our language or understand what we
Vikram,
do.
he's married to a pathologist.
No kidding. That's where this is coming from.
Can't help, sir.
It is unusual for surgeons to have such in-depth knowledge of pathology. So. What does your wife do, Manish?
She is a pathologist at TMS.
Tata Hospital.
So, yeah. She does head, neck, and gynae pathology.
Okay, no kidding. Well, congratulations. I think, well, I married a pathologist too, but I am a pathologist, so that's different. So yes, this is osteofibrous dysplasia, and I think I have a video. Let's see if we play this. I don't know what we play. This was an adamantinoma, so that's on the differential.
Here's a warning. You really shouldn't be diagnosing this outside the tibia or fibula. Two things I must stress. One, most common bone involved is tibia, and in the tibia, this is intracortical. The defining feature is the epithelial component. The difference between the two types is the amount of epithelium. the difference between osteofibrous dysplasia and adamantinoma is that osteofibrous dysplasia lacks epithelial clusters in the stroma. And I can't emphasize this enough, no epithelial clusters in osteofibrous dysplasia. And that's it, guys. Any questions before we hand it to Manish, who's going to share a few cases?
No, sir. There are no questions in the chat box.
Manish, can I ask you, do you biopsy, would you biopsy a lesion like this?
No, ma'am.
Because you can't tell whether there are, there are epithelial cells or no epithelial cells, because
Yeah.
when you do a biopsy, you're only making a very small sample.
Yeah. So what,
So
ma'am,
when
if
would
it
you
is a less,
decide to biopsy, if you decide to biopsy at all?
so first decade of life, tibial lesion, which appears like a cortical lesion with a bowing of tibia, which appears benign, no significant lytic areas or no medullary extension, will not biopsy. In fact, there's a very beautiful paper in skeletal radiology. I think it is somewhere in 2005, which has differentiated the radiological features of OFT, OFT-like AD, and adamantinoma. And that is one of the very good paper that every pathologist can read, because that helps in differentiating the radiological features, and then only we decide on the biopsy. So we don't biopsy a classical OFT. In a very young age, we don't biopsy. If it is like a 14 years, we see a much more lytic areas, MR show the medullary invasion, then only we are going to biopsy. Otherwise not.
Okay. Thank you.
Yeah.
So Manish, would you like to?
Yeah. So I have only 5 cases.
Vikram, you'll have to unshare your screen.
See, I'm wondering how I do that. Ah, there, I think I see it. Done.
Thank you.
Yeah, so we'll start from here, the discriminators. So now we know, so we'll have 5 cases or 6 cases to discuss. So this is the first case, which is a 12-year-old boy, a lesion in the proximal end of humerus. So my first question is whether it is benign or malignant. So Tanvi, you can help me if there are some answers in the chat box. Otherwise, I'll just proceed.
Okay.
Yeah. So what do you feel, if it is benign or malignant?
Benign.
Benign.
Perfect. So looks, yeah. Why benign? Because it has a narrow zone of transition. We can actually mark the lesion below, and there is no periosteal reaction. So we are very clear that it is benign. So now the second question is, if it is benign, then what is the most possible differential? A giant cell tumor, a chondroblastoma, a simple bone cyst, or an osteoidostoma?
GCT.
Yeah. So there we go wrong, because we should know the age of the patient. It is 12-year-old boy. A GCT usually happens in a skeletally mature. And a giant cell tumor should always go to the subchondral area. It should usually involve the epiphysis. Yeah. So a benign lesion in a 12-year-old, little expansion, it's a simple bone cyst. It is not chondroblastoma, because chondroblastoma is epiphyseal. Osteoidostoma is cortical. GCT should happen after skeletal maturity. So we are left with only one differential, which is a simple bone cyst. So the radiology is as simple. If we know the differentials according to age, I think we'll be able to make a diagnosis before even you get the slides. So another case, 17-year-old boy, a metaphyseal lesion. What is the likely diagnosis? An aneurysmal bone cyst, an Ewing sarcoma, osteosarcoma, or a fibrous dysplasia, as we have seen earlier.
Ewing sarcoma.
So why Ewing's, if I ask someone?
Onion peel appearance.
So only onion peel will classify it as an Ewing's?
No.
That you can see in the infection also. So
Ewing's
it's
will happen in diaphysis.
No. So I think that is a very incorrect statement. Ewing's is usually metadiaphyseal. But yes, the most important thing is the two discriminators. It is a permeative lesion, and it is showing an aggressive periosteal reaction. So one thing we are sure that it is a primary malignant bone tumor. And now the last discriminator, which is the matrix of the lesion, we can't see any matrix here. Okay, so a primary malignant tumor which is having no matrix is Ewing's. Fine. So periosteal reaction will guide you between the benign and malignant, but don't make your diagnosis on the type of periosteal reaction and the histology. So it is primary malignant bone tumor based on the radiological features and no matrix which classify it as an Ewing's. Okay, so if I know the radiology, then I think seeing the slide becomes very easy, because then I know I'm going to see for Ewing's, and I think we should be able to make a diagnosis here. Now coming to my fourth question, so the 35-year-old male, this is a surface tumor, slow growing. So what do you feel it is? A periosteal chondroma?
Osteosarcoma.
Which third or fourth? Sorry, I can't get.
Fourth.
Parosteal or fourth?
Parosteal.
So this is very classical about parosteal is you see some cleavage lines here, and it's a very dense forming bone, and the bone is so dense that it almost looks like a normal bone. And I usually call it like a feathery pattern of bone deposition. You see some feathery kind of a structure, like some translucency in the bone. So if you see a very dense bone next to the normal bone, so and which is abutting that cortex, which can be seen much better in a cross-sectional imaging, then more or less you are dealing with a parosteal osteosarcoma. The only issue here is, which Dr. Vikram has also pointed, it looks almost like a normal bone, so it becomes very difficult. So we evaluated our 48 cases of parosteal, and our average number of biopsies to diagnose these tumors is 1.8. So basically, many of the lesions you will not be able to diagnose in one biopsy, because of such a dense bone and a normal looking appearance of a bone, that it requires many of the times a repeat biopsy, because the pathologist will keep calling it as a normal bone. They will not call it as a parosteal, although the radiology looks like a parosteal. So it's a challenge to biopsy a parosteal, and you need to take multiple cores from different directions. That helps. But yes, it is a different. Many of the times we require a repeat biopsy, because in one biopsy we are not able to make a diagnosis. That is the challenge with the parosteal. So this was a classical parosteal osteosarcoma. Now, next, 13 years female. Now you can see in the X-ray the epiphyseal lesion here. Patient has a 4-month history, started after trauma. What is the most possible diagnosis? A tuberculosis, a giant cell tumor, a clear cell chondrosarcoma, or a chondroblastoma?
Chondroblastoma.
Yeah, so why not tuberculosis? Because usually the infections will involve the physis. Okay, so infection will not be epiphyseal. Usually it involves the both sides of the physis. A GCT usually happens in a mature skeleton, although it can go to epiphysis, but it starts from metaphysis going into the epiphysis. Clear cell chondrosarcoma happens in adults. So the only thing that we are left with is a chondroblastoma, and this is very classical that we have discussed in last class. Lot of marrow edema which a chondroblastoma cause. So this is the lesion, and surrounding all that is a marrow edema, which is very classical for a chondroblastoma. So epiphyseal location, benign appearing, in a young age, is centrally located, is classical chondroblastoma. Now the last case, 28-year males, multiple swellings, increasing in arm for last 6 months. So what do you feel it is? An oleus with a secondary chondrosarcoma, an osteochondroma with bursitis, a Maffucci syndrome, or an hereditary multiple exostosis with secondary chondrosarcoma?
Maffucci.
So any guesses? Anyone can make a guess.
It looks like Maffucci, but
So yeah. So the thing is, Maffucci and oleus happens in a situation of enchondromatosis. And enchondromatosis is a metaphyseal disease. It happens inside the bone. Okay, it is an aberration of an enchondral ossification. Okay, but osteochondroma happens on the surface of the bone. So if you can see here, so this is a lesion which is from the surface of the bone. You can see a lesion here, and something is happening here. If you see this cross-sectional imaging, there is an outpouching from the surface, and there's a thick cartilage, the scab, which is appearing bright. So this is something which is happening on the surface of the bone, and from where the swelling is increasing. There is a thickness of the cap. So this is an hereditary multiple exostosis known case with a chondrosarcoma. So I'll just show you a classical X-ray of enchondromatosis so that you can differentiate. So this was the surface region, as you can see here. And if you see enchondromatosis, this is an enchondromatosis where the lesions are inside the bone. Okay. So this is a classical distal radius. You can see a aberration of the enchondromatosis. This is an Olier's disease, and this patient was having a chondrosarcoma in the proximal humerus. So that is apart, but most important thing is enchondromatosis happens inside the bone, while an osteochondroma develops on the surface, and from there, if the lesion grows, then it is an hereditary ectosuture or a secondary chondrosarcoma. So I think, sir, that's it. I will not go into much of a detail. That's it from my side. Thank you very much. It's a good.
Thank you. Thank you, sir.
Thank you, sir.
Can I just make two quick comments? Manish, thank you. That was a really thank you for participating in this for the last for both talks, and it was great. Am I using the word correctly? It was great jugalbandi. Is that the right word?
Yes, you're right.
Okay. I'm sorry. I'm losing touch with my Hindi now. Even though I'm married to a Punjabi, I should be able to speak Hindi a lot better. The other thing I wanted to say is that the students did a wonderful job on both days. So congratulations, guys. You guys are certified to be bone pathologists now. So thank you, and thank you for the invitation.
Okay.
Vikram, before you go, there is a question that I think got passed over, and that is chondroblastic osteogenic sarcoma. But you don't see much osteoid in that, or you don't see any osteoid. How do you know that this is a chondroblastic osteo, or is it a high-grade chondrosarcoma?
So I'll start with that. I mean, Manish, you can talk about the radiology and your approach, but in general, when you have a young kid with a chondroblastic lesion, you should exclude the possibility of a chondroblastic osteosarcoma before calling it a chondrosarcoma. I think histologically speaking, if you see very high-grade cartilage, you must exclude the possibility of a chondroblastic osteosarcoma. So it's unusual for chondroblastomas to show diffuse high-grade cartilage. So that's a sort of another tip-off. So the age, gender, location, radiology, histology. I think it's sometimes a huge problem for the treating oncologist and the surgeon, because you'll get a needle biopsy of this. They'd like to treat all osteosarcomas with chemo up front. Chemo, that's not the way you treat chondrosarcomas. So they often require a definitive diagnosis. Unfortunately, when you put a needle in, all you're getting is cartilage and cartilage. And we are trained not to call things osteosarcoma until you see bone. And at times it's difficult to distinguish between what is bone and some very pink-looking cartilage. So it gets quite complicated. We've certainly had cases where I think we have just gone ahead and said that over the clinical and the radiological, although we're not seeing bone, we think that the clinical and radiological context is consistent with a chondroblastic osteosarcoma, and just go ahead and treat it as such, even though we're not seeing it on the biopsy, and then we invariably see it on the resection. Remember, most resections are post-chemotherapy. That's in children. It gets much more complicated in adults, and we've got into this problem particularly with pelvic chondrosarcomas and chondroblastic osteosarcomas. And that's where I was a part of one of those papers where, remember, about 60-70% of chondrosarcomas have an IDH mutation, either IDH1 or 2. So we had this paper in AJSP about 4 or 5 years ago. Essentially, we used that as a means of distinguishing between chondroblastic osteosarcomas and osteosarcomas, because osteosarcomas lack IDH1 and 2 mutations. But remember, it's not 100%. Often genetic testing on bone specimens fails. So you are highly reliant on histology. And I think the one thing that I've carried all these years, and the one thing I think you should remember is, if you see diffuse high-grade cartilage, you must think of that possibility. Manish probably has some additional comments on that.
No, sir, I think it's a big challenge. But yes, in pediatric age, we tend to have a more of a diagnosis for chondroblastic osteosarcoma. So it's basically on the age, on the radiology, then the pathology inputs, because I think the chondroblastic osteosarcoma and chondrosarcoma becomes it's a difficult challenge when the age is around 30 years, but it is quite easy when the age is little less, maybe around 16 years. Yeah, and sometimes the pelvic location gives us a trouble a lot. So in those cases, we rely a lot on radiology, lot on the bone formation, the permeation, so all, and the type of a bone which is forming. So sometimes the CT scan also helps in understanding the type of ossification, whether it is an ossified lesion or it's a chondroid matrix. Sometimes adding a CT scan also helps here. So, but yes, I guess it's a difficult challenge many of the times.
Well, bone pathology is hard, you know. Bone is hard. Soft
Yes,
tissue is also hard.
I agree with both of you. I have never made a diagnosis of a chondrosarcoma in a 16, 17-year-old.
Yes,
I've
yes.
never done it. I don't think that you get very well differentiated chondrosarcomas at that age. So you get these high-grade chondrosarcomas, chondroid tumors, which are extremely high-grade, and I just don't look too carefully for bone or osteoid. At that age, it is a chondroblastic osteogenic sarcoma,
Agreement.
and that's the way that it's going to behave.
So, Dr. Borges, you wouldn't send the surgeon back for more tissue?
No, I wouldn't, because I think that that's what it is. It's going to be. It doesn't make sense. And how much more tissue are you going to get to look for that little bone and osteoid when you know that everything else fits into into this diagnosis of an osteosarcoma, albeit that it's got a lot of chondroid or chondroblastic stuff in it. At the age of 30, Manish, the issue of an osteosarcoma versus, one that's got a lot of chondroid in it versus a chondroblastoma. I don't know that osteosarcomas at the age of 30 actually respond as well to anterior chemotherapy, do they?
Yes, ma'am. Till 30, I think till 45.
All right, let's say 30, but what happens at 35? What will happen at 40?
So, ma'am, still the protocol remains the same. Even if the patient is 50 years, we have a diagnosis of osteosarcoma, we are going to start with chemotherapy. In fact, any chondroblastic osteosarcoma, you will see a poor response to chemotherapy. Because chondroblastic osteo usually will not see a good response to chemotherapy. That is there because that component does not respond. But yes, still we go ahead with the chemotherapy. The protocol remains the same. But yes, if we are in a very significant dilemma, we do an upfront surgery because the outcome remains the same.
That's what I was getting at, that this rigidity about, yes, we must do anterior chemotherapy and then resect, to me is being extraordinarily rigid, particularly when you have crossed, you're an adult and you know that you may not get the same response to anterior chemotherapy, and if it is resectable, I guess that makes more sense, and then give adjuvant chemotherapy depending upon what you see in a whole specimen.
We many of the time follow this policy.
Good. Anyway, it's nice to know that happens. Thank you all of you for your contributions. Thank you, Vikram. You had some very interesting video.